So that provide a nice segue to the next question. I'm going to ask Dr. Tagawa, who was also an investigator in the VISION trial and was a co-author on the New England Journal of Medicine paper on the VISION trial, on the primary results of the VISION trial. So Scott, please tell us about the VISION trial and how, and then we can discuss how lutetium-177 PSMA 617 is going to be incorporated. How would you use this agent in the treatment of your patients with metastatic CRPC? And then after that, we can talk about how this agent and similar agents or approaches are going to be moving to other earlier states of prostate cancer. So let's start with the VISION trial first.
So the VISION trial was designed in a way analogous to the Alsimca trial, the first approved radionuclide that led to an overall survival advantage, radium-223 for metastatic CRPC. In terms of most of the factors in terms of study design other than imaging selection. So the idea was to have a patient population that had all other drugs known to be a benefit. So chemotherapy, hormonal therapy, at least one of each was required. But if they were appropriate for radium, they should have got that before. If they were appropriate for a PARP inhibitor, they should have got that before, et cetera. And then function as essentially an add-on. So patients got a standard of care systemic therapy as limited and defined by the trial for safety reasons, but they got a standard of care therapy with or without lutetium PSMA 617 as Jeremy described what that is. And the trial was designed with alternative primary endpoints of overall survival and radiographic progression-free survival. So if only one of them were positive, the trial would be declared positive. And fortunately for patients, hopefully sometime soon, both happen to be positive. So there was an overall survival benefit of nearly 40% in terms of hazard ratio, a radiographic progression-free survival of 60%. Fairly impressive numbers for a heavily pretreated patient population, which I believe is not the optimal patient population for this drug to work well, as this was also mentioned by Dr. Clay. But fortunately it worked. That is in tandem with a randomized phase 2 trial, a slightly different patient population, more heavily pre-selected based upon imaging, which we can go over if you want, but a head-to-head trial of patients with metastatic CRPC, heavily selected by imaging with prior docetaxel. As it turned out, about 9 in 10 had prior AR pathway inhibitor. Head-to-head against cabazitaxel, and lutetium PSMA 617 was also better than cabazitaxel in terms of PSA endpoints. PSA response was the primary endpoint, also PSA progression-free survival. They're important for the practicing physician that's out there. There are adverse events that are associated with lutetium PSMA 617. And I don't want to downplay them so much. I would say overall, this treatment is very well tolerated, but it's not like there's none. So as in any positive study, patients generally in the positive arm are going to be exposed and follow longer for adverse events. So we have to keep that in mind. But I categorize these in 3 major categories. So constitutional, so more fatigue, hematologic, so more myelosuppression, particularly in terms of thrombocytopenia, generally not with bleeding, and then kind of the GI tract, starting from the mouth in terms of dry mouth, as well as some nausea, generally low grade and generally reversible, but those are adverse events that have been described with this more than control. Despite that, having more adverse events in a presentation by Karim Fizazi at ESMO 2021, there was a significant benefit in terms of time to deterioration of patient-reported outcomes. So despite more adverse events, because likely of better cancer control, the time to deterioration of quality of life by FACT-P pain by brief pain inventory, as well as symptomatic skeletal events, was all in favor of the lutetium PSMA 617 treatment arm.
Those are very, very good information for our colleagues out there who may be listening.